Good morning, pleasure to be here. Now, as many of you will know, PCR is excluded from the EORTC MSG criteria. In 2002, it was excluded because of the presence, let's see if I can get this to work, of false positivity and the lack of a standardized commercial method. Later, after revision in 2008, Ben told us we'd hoped they would progress a little bit further, but the lack, again, of a standardized and commercial option and validation of the tests had not been attained, and it was consequently excluded again. Now, the EORTC MSG criteria are under revision for a second time, and PCR is amongst the tests being considered for inclusion. So a panel of us that I will describe later were asked to determine whether there was sufficient evidence available for PCR to be included within the criteria. And that's what I'm going to present to you today. Now, Martin has already done a fantastic job of describing some of the background behind the test. I'm not going to go into too much detail with respect to beta-glucan galactomannan, and to be honest, not that great a deal of detail with regards to PCR. Just a little bit of points in terms of comparison between the tests, which are valid when it comes to a diagnostic and with respect to a screening strategy. So the process, as you can imagine, is a literature review. What we were looking for was comparison with the other biomarkers, which is pretty much predictable. And what we did is we covered the period of 1993 to date. I say to date, that was probably sort of middle of 2015 by the time we'd done the process, so there's been a little bit of delay. Now, 1993 was when we saw the first papers describing PCR for the use of particularly invasive aspergillosis, for the diagnosis of invasive aspergillosis. But it was also another date within that was in 2000 where we started to see real-time PCR methods, and they are something that's really pushed forward the molecular diagnosis of fungal disease. Now, in that, we covered approximately 400 papers, and we targeted specific evidence. The issues considered: what fungi? Obviously, that's a major question to start with. Now, in the developed world, we're looking at invasive candidal disease, invasive aspergillosis, pneumocystis, cryptococcosis. Occasionally, we get presented with the endemic fungi, mucorales, phaeohyphomycoses, and the hylohyphomycoses. That pretty much covers most things we will see. There are a few other things in there which may occur, obviously. What patients? Usually, we're dealing with immunosuppressed patients. Obviously, we've seen cryptococcosis in immunocompetent patients in the northwest of America. But generally, they're going to be immunocompromised. But it's a question of whether we're just going to focus on hematology, whether we bring solid organ transplantation in there, other types of immunosuppression such as HIV, and a big question of whether we just look at adults or we include pediatrics within the population. What type of specimens and how these impact on what the strategy that we can use within the laboratory, whether we have invasive specimens such as BAL or CSF or tissue, or whether we just focus on blood-based specimens. And what are the technical issues that which will give us a good idea as to whether tests are performing up to a good enough standard. So obviously, we're going to look at methodological recommendations. Do we have standard methods that can be applied across centres? And preferably, are there standardized commercial options available to us? And are there studies that compare these methods? Do we have control material available that tells us that each PCR assay being performed is working to a required standard? And do we have a quality control scheme that can tell us that individual centres are performing to the required standard? And both of these should be independent of commercial assays, or commercial companies producing assays. Obviously, we're interested in clinical performance, the sensitivity and specificity, but more so, have these assays already been incorporated into sort of neutropenic care pathways or other types of care pathways where we see effect on patient management and effect on local hospital policy, i.e. is there clinical utility? Oh, let's just go back there. Right. I mentioned we're going to compare these with other biomarkers, but also, does PCR provide something that the other biomarkers cannot provide which is of use in a clinical setting? So our general findings were there was sufficient evidence for Aspergillus PCR. Now, unfortunately for Candida PCR, we are where we were 10 years or maybe 15 years ago with respect to Aspergillus PCR. There are some commercial assays available, I will give you that, but there's been limited evaluation in the clinical setting, and there's limited standardization of Candida PCR tests, so we couldn't really include those. With respect to many of the other tests, for the mucorales, hylohyphes, and the phaeohyphes, there simply aren't enough assays available. For Cryptococcus, the CRAG test works perfectly well, and we actually don't need a molecular method for the diagnosis of cryptococcal meningitis. Now, for pneumocystis, we actually put forward that it probably should be included for the diagnosis of pneumocystis disease. However, there's another group focusing on pneumocystis infection within the EORTC, and actually they came to the same conclusion that pneumocystis PCR should be included in the EORTC MFG criteria. Now, the data mainly was focused on hematology patients. For populations outside of that, we were struggling to find sufficient evidence for the use of Aspergillus PCR in those groups. There are case studies and there are some small studies which do provide evidence, but it wasn't sufficient for inclusion. And this was mainly the adult population. If you look at the evidence base, there's approximately a log more information for the adult heme population in comparison to the pediatrics. And the data was robust for blood and BAL specimens. Now, given that PCR, when designed properly, should have a greater analytical specificity than both galactomana and beta-D-glucan, which has been described as pan-fungal. PCR could probably be applied to tissue specimens and maybe cerebral specimens on the basis that when it is positive, it is likely that that patient does have disease. So when it comes to methodological standardization, yes, we do have recommendations. The European Aspergillus PCR initiative was developed or put together in 2006. And what we did find was that PCR itself, the PCR amplification process, was not rate limiting. It was DNA extraction was what we had to focus on. So you could pretty much use many of the PCR amplification systems in place because they all perform to a very similar standard. But DNA extraction was the problem that we had to crack. And since then, we've provided extraction recommendations for whole blood, serum, and plasma. And as Martin has already said, we are focusing on BAL at the current time. We've had multi-center case control studies completed, which have confirmed the performance in whole blood, serum, and plasma. And we've recently published validation in an animal model, which does show some very interesting information with respect to the timing of positivity, in that PCR was positive prior to both galactomana and beta-D-glucan. Conversely, galactomana and beta-D-glucan did show an increase in index or increase in concentration with the progression of disease, so they were useful in that scenario. We do have randomized controls ongoing. We have finished the Ambigard study and the EORTC study looking at, I think, is it prophylaxis versus a diagnostic-driven approach? Rosemary? Empirical versus a diagnostic-driven approach. That we will be testing the samples now over the next sort of 9 to 12 months to get that sorted. And of course, we do have commercial options available. I think there's now about 12 different commercial Aspergillus PCR assays available to us. What about control material? Well, if you buy a commercial assay, they will provide you with a positive and a negative control. Now, but the thing is with that, we don't know, with respect to the positive material, what it is. Is it plasmid? Is it genomic DNA? We do not know the concentration of that. So it makes it difficult to say how valid that is with respect to the clinical test. So it needs to be independent, and we do have an independent DNA calibrator that was put together by the Invasive Aspergillosis Animal Model Group and the Aspergillus Technology Consortium, both NIH-funded organizations in the US, who collaborated with the European Aspergillus PCR Initiative. And we validated DNA material that is available to all centers, although I am aware that many centers have found it difficult to get their hands on this material. So if you do want it, you can contact me, and I will get you in touch with the Americans who said they were happy to provide you with this DNA material. Now, what it allows us to do is compare the performance of PCR systems. But more so, we're looking to develop a WHO international standard for Aspergillus PCR. We already have things for CMV, I think they're working on it for EBV, and we have it for HIV, Hep C as well. So what it would do, it would negate the need for an individual test, because this international standard would go through the entire molecular process, from DNA extraction to PCR amplification, and would tell us if that assay, if your assay is working to the desired standard. And would bring it in line with other etiologies. We don't have a single molecular test for HIV. We don't have a single test for Hep C. So the argument that we need a single test for Aspergillus PCR bucks the trend, to be honest. I don't think it is necessary. What about quality control? Well, QCMD will, for a small fee, provide you with a panel for Aspergillus PCR. They will also do it for pneumocystis PCR, and they also have a panel for Candida PCR. When you return your results and some technical information within a particular time frame, they will then compare your results as with respect to the panel, so you get performance with respect to the panel, but also with respect to performance of other centres. Now, the European Aspergillosis PCR initiative have responded to their users and are doing a similar process, although originally we weren't designed to do that. Both these are independent of commercial manufacturers. It's important to add that no other tests currently have independent QC. We do for galactomannan have the proficiency panel, but that's developed by galactomannan. You return the results to those. The French apparently do have something in line for galactomannan, but getting hold of galactomannan basically is very, very difficult. It comes from Jean-Paul, I think, in Paris. He has some. And I know that Sheila, who's in the audience, is going to be talking after me, might be mentioning something with respect to Nequas and bringing on a galactomannan panel in the UK. So that would be very, very useful. Now, as I mentioned, we have commercial PCRs available. And the fact is, if you were to take your commercial PCR assay and combine that with the European Aspergillosis PCR Initiative recommendations, you would have a fully standardized approach. And it's important to remember that QC drives performance. If you do not know that your assay is underperforming, you will not strive to improve it. You will carry on blindly providing inaccurate results. And that's the importance of QC. So, in terms of validity, sensitivity, specificity. Now, we've already discussed differences between screening and diagnostic strategies. So when you're testing blood, you need to be going down a screening route where you're testing lots of samples on a regular basis. And what it's designed is to have a high sensitivity and negative predictive value to exclude disease. And this is beneficial for low incidence diseases such as fungal disease. Now, these are meta-analyses that have been published over the last sort of 5 to 10 years, describing galactomannan, beta-D-glucan, and PCR. The data might vary a little bit because in some of them they provide you with a summary ROC analysis. And in doing so, they provide you with estimates of sensitivity and specificity based on the ROC curve. So I've recalculated them and provided you here with pooled sensitivity and pooled specificity. And this has been published in CID. Now what you're looking for in this scenario is we need high sensitivity. And so what you find is the sensitivity of PCR by meta-analysis is superior to both galactomannan and beta-D-glucan, and provides us with a negative likelihood ratio of 0.15. If you get to 0.1, a statistician will tell you that's enough to exclude disease. So we're not quite there, but we are close to being where we need to be for a single assay. If we look at the combined test, combining sensitivity and specificity, you'll see it's comparable to both beta-D-glucan and galactomannan ELISA, despite the limited standardization of these tests. If we move on to another scenario where we're looking for a diagnosis of disease in a suspected patient, we're looking at an infrequent test on something like a BAL. And in this scenario, we need high specificity and a high positive predictive value. And again, we've got the meta-analyses here for galactomannan and for PCR. And you can see that the specificity for PCR is superior to that of galactomannan. Okay, combined strategy is comparable. And what we would do from the scenario, the specificity drives a likelihood ratio positive of 12, which a statistician will tell you once that's greater than 10, that patient has disease. So PCR in this scenario is sufficient to confirm disease. As I mentioned, comparable performance despite limited standardization. Martin has already discussed the problems with beta-D-glucan in BAL specimens, but you can see the specificity is poor, likely a result of candida colonization. And just to highlight the point, well-known fact that culture of BAL is probably around 50% in cases of invasive aspergillosis. So it shows that it's an improved assay to go down, an improved route to use PCR in this scenario. So I've said, well, despite standardization, we're actually getting performance that's comparable to glucan and comparable to galactomannan. So the question will be, well, if we actually look at standardization, will it improve performance? Now, this is an independent meta-analysis performed by our American colleagues that looked at PCR and looked at whether they were following the recommendations as put forward by the European group. And what they found, there was a trend towards improved sensitivity, 87 versus 82%, but a significant increase in specificity when the recommendations were followed. Now, they didn't quite follow, for me, compliance, you're either compliant or you're not. They allowed one deviation within their study from our recommendations, and that was to overcome some of the limitations in terms of numbers. So even with this caveat in there, it was shown that standardization will improve PCR further. So, false positives, false negatives. We are now aware of problems of false positives with PCR Vacutainer contamination. Manchester has published some work on that quite recently. Molecular reagent contamination, we've known about that for quite some time. Unfortunately, many of the reagents we use, many of the enzymes we use in molecular biology are derived from fungi, or the manufacturers have decided that they're going to make recombinant enzymes, and the vector they're going to use for these recombinant enzymes are going to be yeasts. So we end up with a DNA or candidate DNA contamination. But we are aware of those problems. We can also have issues with colonization exposure. And the problems we sometimes face is that our true positives and false positives, particularly when we look at circulatory samples, are going to be very, very similar. We can also get false positives by poorly designed primers and probes. False negatives, pretty much the same with galactomannan and beta-D-glucan. You can have limited circulating biomarker that is affected by antifungal treatment. But this can be reduced by testing multiple samples. And again, you can get false negative results if your oligonucleotides are poorly designed. Now, we're aware of false positives for PCR, but we're aware of false positives for galactomannan, and we have false positives for glucan as well. And to be honest, lots of these the limitations are specific to the actual test themselves. So as long as we're aware of the problems and the likelihood of false positivity, there's no reason to be excluding one test and then including others within the criteria. So utility, has it affected patient management? This is our local experience. I know we are quite unique in Cardiff in the way we do things. This is a publication that Rosemary published around 2013, described yesterday in some detail. We're looking at sort of 550 patients, of which we had 53 cases of proven probable disease, and we used galactomannan and PCR to screen them twice weekly. In this scenario, we had a really high sensitivity of 98, combined sensitivity of 98%, and basically our negative predictive value was nigh on 100%. So when both tests were negative, we could exclude disease. And that was despite the patients receiving itraconazole, most of the patients receiving itraconazole, and we did do levels, if not ambisome, for those receiving things like vinca alkaloids. Now, the interesting factor here was what was the first biomarker positive. Now, in our 53 proven probable cases, PCR was the first biomarker positive in 23, ELISA in 15, and PCR and ELISA simultaneously positive in 7. So in 85% of our cases, biomarkers precede radiological signs by up to 4 months, which is a long time. But the interesting one here for me is that we had 23 possible cases. By definition, galactomannan negative. Now, if PCR were included in the EORTC criteria, as 17 of these 23 were Aspergillus PCR positive, the actual sensitivity in our study for galactomannan would have fallen to 67%, and our PCR would have remained closer to 90%. So PCR does have a role, and it basically does recognize some of the limitations of the EORTC, which is just reliant on galactomannan or beta-D-glucan. And culture, in terms of BAL culture in the study, was only 20%. So there have been quite a few studies now showing the clinical utility, incorporation in the other care pathways, and pretty much they're all confirming that biomarkers are earlier than the clinical presentation. In our situation, PCR was earlier than galactomannan in more cases than not. And in the one study from the Spanish study, which was a multi-center study, they've actually seen a reduction in cases of proven or probable invasive aspergillosis. So they've seen an incidence rate reduced. And that was put down to biomarkers providing an earlier opportunity for basically intervening and providing some sort of medication. They can be used to exclude aspergillosis through combination testing, gives us a high sensitivity and high specificity. But multiple positives do give us a decent probability. I mentioned this yesterday, when you've gone up from around 5% to 55%, I recognize it's still a flip of a coin. But in this scenario, the likelihood ratio positive is greater than 10, is about 11 in our scenario. So a statistician would tell you if you multiple positives by PCR and ELISA, that patient does have aspergillosis. And we've actually seen a massive reduction in the use of unnecessary antifungals, averaging now, from when we started this, we've seen about a £500,000 annual reduction in the use of antifungal therapy. So the summary points for these is that, yes, there is some technological variability, but now we do have methodological recommendations and commercial assays are available. By combining a PCR assay with these recommendations, you get standardized methodology. And despite the variability we've seen in the methods, performance of PCR is comparable, at least comparable, to glucan and galactomannan. But we do have added benefits. Now, if we consider that the EORTC MSG criteria, When we have the mycological criterion, all it's doing is add in etiological certainty. You've already got information, clinical information, that's in keeping with a diagnosis of fungal disease. The mycology then tells you, yes, it's specific to Aspergillus. So on that basis, your assay specificity, analytical specificity, is paramount. By design, glucan detects a broad range of fungi, so it can't tell you that it's Aspergillus. We know that galactomannan cross-reacts with other fungi than Aspergillus. So, when designed to be so, Aspergillus is the only assay that can be, Aspergillus PCR, is the only assay that can be genus or species specific, if accurately designed. It can also provide us some information with regard to resistance. We know we're seeing azole resistance. And this can be applied direct from the specimen, so we're not then necessarily reliant on the limitations of culture. So in terms of analytical specificity, branching out a little bit on that, obviously it's the range of detection, how many pathogens you're trying to detect, but the downside of that is how many things that does it pick up that you don't want to detect. Now, as I mentioned, it's the only assay, other than culture, that when designed to be so, is the only assay that can be truly pan-fungal. But conversely, it's the only assay that could go down to a species-level identification other than culture, which is useful in epidemiology and is also useful in patient management when you might have species that are resistant to certain antifungals. Now, I've already mentioned the point about mycological evidence being important in analytical specificity, but it is within the EORTC criteria, the analytical specificity of the mycological criterion is paramount, and basically PCR is the only one that can provide this to the highest level. So, just moving on briefly with respect to antifungal resistance, in particular azole resistance in Aspergillus fumigatus. We know this is becoming a bit of a problem. Now, molecular tests are the only non-culture route to determining whether the genetic mutations that infer resistance are present. These have been applied to clinical samples, BAL and serum, and they overcome the limitations, and we say if it's 50% sensitivity for culture, these have been shown to be closer to sort of up to 80% in BAL specimens. So it provides improved sensitivity and actually rapid results, and commercial options are available. Whether or not they will reduce mortality is yet to be seen because they haven't been used in routine for long enough to determine whether that's the case. However, Arturo Casadevall put forward that fungi were responsible for the demise of the dinosaurs. Now, he put forward in his study that at the end of the Carboniferous period, there was a huge amount of mass deforestation. Now, what you get in nature when you get a lot of dead trees lying around, you get a lot of fungi. So there would be a lot of fungi in the atmosphere circulating around. So dinosaurs being exothermic are prone to lung disease. So they would have been breathing in a lot of fungal spores, and he put forward that that had a role in the extinction of the dinosaurs. Whether it was that or massive meteorites landing in the Gulf of Mexico, you can decide, and I don't know how we study it and determine which is correct, but it's just a theory anyway. Now, if like me, I'm a massive fan of the sort of the sci-fi horror scene and the zombie sort of films and games you can get. Now, I don't know how well this shows on here. This is a slide from one of the games you can get, which is The Last of Us, which is basically when the people all become zombies. And what you can see here is some sort of hyphal structures which have been seen within the patients. And then the one at the top here is taken from The Walking Dead, which is this popular program on Fox. I haven't got shares in it, by the way, so you're okay. And what you can see here is some sort of hyphal invasion. I don't know how well it presents into the brain of the person. Now, in this scenario, the only way of sort of stopping this is to sever the central nervous system. Now, I'm not suggesting that we do that for our patients, but what we want to avoid is getting to a situation where, because of delayed inappropriate therapy, the mortality rate of our patients is going to approach 80 to 90%, and all we're left with doing is palliative care. So direct azole resistance has been done through CYP51 mutations, mainly applied to tissue and BALs, but the commercial assays, in particular the pathognostic aspergillus assay, has been applied to BAL specimens, and 8 out of 11 samples from these patients, they were able to determine the profiles and whether resistance was possible. We've actually done that to blood samples, and we found about 50% of our patients with proven probable aspergillosis. Within the study, we could determine a resistance profile. None of the patients had azole resistance, but we were able to determine that. All these were culture negative. Obviously, we got next-gen sequencing coming on board, and would provide us with full resistance profiling, SNPs, novel genes, novel targets, for instance, for drugs. We saw a talk yesterday, and also important in epidemiology. So I think molecular has a long way and will provide us with a lot of benefits. So the proposal that was put forward was that despite historical limitations, the data is sufficiently robust for PCR, in particular Aspergillus PCR, on blood and BAL to be included as a mycological criteria for probable aspergillosis. And this is going to be aimed at the adult hematology population. Now, this was put forward in Trends in Medical Mycology in October, and this went out for consultation. I think the consultation period is now closed, Rosemary? I think it was. Have they extended it? So you still have time to object or support the proceedings if you so wish. And this was the review panel who were responsible for going through and doing all this work. And at that point, I would like to stop and take any questions. Thank you very much.